Hi, this is Ed Fitzpatrick. If you enjoy local politics as much as I do, be sure to join our friends at Rhode Island PBS for the show A Lively Experiment. Hosted by Jim Hummel, the weekly series features journalists, pundits, and politicians debating the stories and issues that matter most to us Rhode Islanders. Tune in to A Lively Experiment and be part of the conversation. Fridays at 7 p.m. on Rhode Island PBS and wherever you get your podcasts.
From the Boston Globe, this is Rhode Island Report. I'm Alexa Gagosz, in for Ed Fitzpatrick. Welcome back to the podcast where we bring you big conversations from our very small state. We've got a special bonus episode for you today. Last week, in front of a live audience, my colleague Dan McGowan and I moderated a discussion on Rhode Island's healthcare crisis with Rhode Island Attorney General Peter Neronha, Brown Health President and CEO John Fernandez, and Maura Iversen, the Dean of the College of Health and Wellness at Johnson & Wales University. This is a lightly edited recording of our conversation. I hope you enjoy it.
When you want to go beyond the headlines, let me recommend Rhode Island PBS Weekly. Rhode Island PBS Weekly is an award-winning news magazine broadcast that gives you the full story, powered by investigative journalism and narrative storytelling. New episodes of Rhode Island PBS Weekly drop Sundays at 7:30 p.m. on Rhode Island PBS. Watch past episodes at ripbs.org/weekly. That's ripbs.org/weekly.
Thank you so much, everyone, for being here tonight for another edition of Roadmap Live. Many of you we've seen in this room on a number of occasions over the last couple of years since the Globe launched in Rhode Island. I do this every time that we have these events, but I want to emphasize once again that we have an office in this building. We are here every day. We live in this community. This healthcare crisis affects us. I have a 2-year-old child who we're going through this. We're looking for primary care providers. We have all the same challenges. So for our rather large team here in Rhode Island, this is a very real crisis to us. Let me introduce, starting with John Fernandez, who's the president and CEO of Brown Health. Maura Iversen, who's the Dean of the College of Health and Wellness at Johnson & Wales University, and of course, Attorney General Peter Neronha. The General has graciously agreed not to prosecute anybody for acting out of line tonight, so we appreciate that, General. I think he said to me, it's not his administration that would be doing that. You know, honestly, we have the clock ticking, so I think we should get right into it. And I'll start with you, Alexa.
Sure. Dr. Mike Wagner, who is the CEO of Care New England, was also supposed to be here tonight. Unfortunately, he called us yesterday and said he was pulling out due to the ongoing strike. UNAP, the union that represents many nurses and other healthcare workers across the state, but including at Rhode Island Hospital, are demonstrating right outside for an informational demonstration. John, what's going on right now between contract negotiations? This contract went up back March 31st of this year. Where do things stand right now?
So right now we are in negotiations with the union. We have been all along. We have our next meeting next Thursday on June 5th, and then another one scheduled for June 9th. So we're trying to figure it out with them.
It's a diplomatic way to put things. But I will say there are, of course, always going to be rumors of a strike. Whenever there's some type of demonstration going on with a union, I don't think that's a secret to anybody in this room. But what happens if the state's only level 1 trauma center goes on strike this year?
So if it comes to that, which I hope it doesn't, we will be open for our level 1 trauma center. We'll have to downsize the hospital significantly, probably in half. To give you a perspective on that, that's about 300 to 400 beds. So that would be a disaster. It would make our crisis, whatever is worse than a crisis, would be a real problem. So we're doing everything we can do to avoid that.
We're going to move back to that, but I want to go to the Attorney General. I think everyone here saw the headlines. Anchor Medical shut their doors. 70 or so workers, including clinicians, were laid off at Providence Community Health Centers. Like, what is going on with Rhode Island right now in the healthcare landscape?
There's just not enough revenue coming into the system. And that's because it's a long answer. I'm not going to give the long answer. But if we don't bring up our Medicaid rates, if we don't bring up our Medicare rates, if we don't bring up commercial too, then our system is going to have spectacular failure. I mean, the reason Roger Williams and Fatima are on, really a knife's edge, as I said earlier today, is because, they've got to get to a point where they can break even and invest back. How they get there with these reimbursement rates, I think is a real question. And I think that is the fundamental reason why, if there's an issue with the bond sales, that's the fundamental issue. So when we talk about how do we change that dynamic, if we want to stabilize healthcare, it's not through gimmicks, it's not through Band-Aids, and it's not through 10 million here and 75,000 there. It's get those Medicaid rates up. Look, commercial, see Martha Wofford out there, Blue Cross, among others, has invested in primary care. If you look at how much they're carrying or pulling the train, they're carrying and pulling the train way more than Medicare and Medicaid is as a function of how much is being driven back into the system. So I understand the frustration that the private insurers have when our governmental insurers don't do enough. They've got to do more too, respectfully, in my opinion. But we as a state have to commit ourselves to raising our state insurance. That's Medicaid. And look, that's not for people who are poor and not working. That includes working men and women too, and children in working families. We got to drive more revenue into the system. That's the fundamental problem.
Peter, can you give us, for those of us who are not well sort of informed on, particularly on the bond situation with Charter Care and the sale, I guess the number one question I think I get a lot is how close are these hospitals to potentially closing?
Well, look, the stakes are high. If they don't sell the bonds, they can't operate. They need to raise that money to operate. The sale price is irrelevant, frankly. There really isn't a sale price, but they got to raise this money to get them started. My office has dragged $50 million out of a private equity firm that once owned them to help them get the start they need. But they've got to sell these bonds to get the transaction closed with Prospect. If they don't, those hospitals will go back into the bankruptcy court in Dallas as assets of Prospect, and they could close, and the underlying real estate and the what's called personal property, but the equipment and all could be sold. Look, we're trying to avoid that, but one way that you make those hospitals a going concern for the bond purchasers is to change the overall environment in Rhode Island. That would not only help those hospitals, but would help Brown Health, would help us build our workforce, those great men and women that are outside lending their voices right now, pay those workers the kind of salaries that they deserve for keeping our healthcare system afloat. But we've got to raise revenue into the system. We're behind Massachusetts and Connecticut in all three buckets. And I'll just leave you with this. And we had a slide up on the screen today in the office. Just to understand this, right now, if you go in and you get a physical and you're a Medicare patient, the provider gets $100. If you are a commercially insured patient, like from Blue Cross, you get $200. And if you're a Medicaid insured person, you get $37. So you can see how commercial is pulling the train. Medicare's, where Medicare is, they're the benchmark. And so Medicaid is way behind it. That's why, because I'm particularly concerned about primary care, we proposed today to lift Medicaid to 100% of Medicare to stabilize primary care at a minimum. We should go farther. Some of the legislation I'm sure John will talk about and I support. But boy, we've got to solve for primary care right now.
Maura, you were just nodding your head when he said that we're way behind Connecticut and Massachusetts. You've worked in both states. How do we compare to our neighbors?
Well, I know with respect to Massachusetts does have a higher revenue per Medicaid patient, but we're ahead. Rhode Island is ahead of Connecticut, which is kind of interesting. I'm not really sure why there is that difference. With respect to my experiences, if I think about like access to care as an example, one thing that we've tried in the hospitals I've worked in Boston is using patient navigators. So having individuals that have a baccalaureate degree, although there's no certification, but education and how to help people navigate this maze of healthcare insurance has really helped us with providing more equitable care and greater access to care. So that would be, one thing that I posit at our university at Johnson & Wales, which we're a very new College of Health and Wellness. We just got accredited for our nursing program. We have a physician assistant program, an occupational therapy, a physical therapy program starting in June. And we have a master's in public health. But within these disciplines, there's a lot of individuals that can participate in primary care. OTs and PTs can provide primary care for preventative health. That's part of their scope of practice. With respect to the mental health challenges across the country, but within Rhode Island, most people don't know that occupational therapy started as a mental health provider of care. And in fact, their decline in mental health services is a function of CPT codes and not being able to bill in the same way and payer influence on that. So looking at partnering between healthcare systems, the government, and educational programs, I think, could help us to address some of these challenges that we experience.
Maura, can you walk us through a little bit about, I'd love to know sort of on campus what things look like. I mean, what's the demand look like right now for people who want to go into the nursing program or who want to get into this? Because I'm always, I've had this discussion when it comes to, public education, right. And we keep hearing, teachers it's hard to fill jobs. You're not seeing as many people enter the workforce. Are you seeing a similar? Do you feel like you are getting still a lot of students who want to be involved in healthcare?
We certainly, for our physician assistant program, we have over 1,000 applications for 36 spots. And physician assistants are one strategy, and nurse practitioners, which can practice autonomously in the state of Rhode Island, one way to address the primary health care challenges that we face. The long-term strategies for CMS and Medicare and Medicaid, that's outside my realm, and I'm glad I have a gentleman on either side of me to address that. But having more physician extenders, providing care and reimbursing them accordingly and providing appropriate salary, I think is an important strategy to use. The one thing I'll say as well is just recently, the Chronicle of Higher Ed showed that regional universities generally recruit students within a 50-mile perimeter of their institution. Those individuals are more likely to stay within the state. They're also more likely to take jobs in community healthcare centers within rural areas. So if we look at our data right now, among our physician assistant students, about 25% are from the Rhode Island area, but 40% stay in Rhode Island. So you get them here, they want to stay here. Of our newly accredited nursing program, we just graduated the cohort in December, almost 80% stayed in Rhode Island. So I think it's important to think about the revenue an educational institution regionally provides as far as workforce, because we know that Medicare and Medicaid is disproportionately high within the state of Rhode Island recipients. So if we can provide greater workforce through an educational institution and workforce from a healthcare perspective, I think that would help our state to level out.
And John, can you walk us through sort of the state of the workforce? And I recognize it's coming from management side, but the state of the workforce at Brown Health. Where do you have holes? Where do you need more employees? What's the situation at Brown Health?
So we have about 20,000 employees across our health system. I'd say the cute short answer is probably almost everywhere, but particularly in nursing. It's getting better, but it's not. We have a long way to go. Techs, radiology techs, primary care. We are recruiting constantly. So I would say that's one of our top priorities. How do we retain people and recruit them into the system?
I guess that leads to the obvious question that if I don't ask, the folks from UNAP are going to haunt me in my dreams.
Yeah.
Understandably so. I don't need you to negotiate in public. I get it. These things are tough, but one of the key points of contention is around health coverage for nurses. And I mean, what does it say about the state of our situation that you're asking nurses to potentially pay more in healthcare at a time where nobody can afford it?
Yeah. So first, I'm not negotiating here in public. We have meetings coming up, and we'll do it there. I think we're offering a terrific package, but I would get back to the money problem. One of the reasons it's hard to pay more, just do the math yourself. If you increase compensation by 5% and your rates increase at 1.5 to 2, you don't have to be a mathematician to figure that out. And over time, that creates a real problem. Just to give you a few stats, in the last 3 years, all the hospitals in Rhode Island lost $253 million. That's unsustainable. Brown University Health, formerly Lifespan, you look back the last 10, 12 years, this problem did not just come up this year. This has been building for years and years, and we better put a stop to it or there's going to be severe consequences. If we think Roger Williams and Fatima are a problem and closing a banker, that is going to pale in comparison to what happens when we lose all the talent that goes a few miles down the road here to Massachusetts.
Well, paint us that picture. I mean, how close are we to, and I assume some of this is already happening, but I mean, are we 2 years away from a massive problem, or is it not actually a timeline? Is it just going to happen over time?
So I'd say a couple things. There's a bill we have, House Bill 5790. We're proposing $90 million that gets matched 2-to-1. That would pay for a lot of the things that the general pitched today for primary care, for our doctors. It helps with wages. It helps with the construction projects. If that doesn't happen, our organization and others will have to go, what are we not going to do? What services are we not going to do? And we put it out publicly, at least internally, but anything when you have 20,000 people becomes public pretty quick.
We have a copy of that notice.
I know. But that means we will take services that are not critical to our mission and say, we're not going to do those, or construction projects at Rhode Island Hospital that is a complete mess by any standard you look, and there's some great parts, but we have elevators that go to our cath lab that floods run through when it rains. That is not like okay. And we have settled too long. I've only been here 2 years, but we have settled for too long. Okay is okay, and we need to stop it now. It's not 2 years. It has to be decided in this legislative session, or else it's going to go downhill really quick. If you want the bonds bought, tomorrow announce that they supported House Bill 4790, approve the money, and I'll bet those bonds get sold in a minute.
How much confidence do you have that it will actually pass, though? Because we spoke to the speaker yesterday, and on speakerphone, he must have said 4, 5, maybe 6 times, there's no money. We have no money. There's nothing.
There's plenty of money. It's about priorities. I know there's not plenty of money, but it is about priorities. What is more important than your health? I don't know. I'm biased because I run a health system, but if you want to find the money, whether it's 90 or 70, when you're matching 2-to-1, I'd find as much, if it were my house, I'd find as much as I could to match it 2-to-1 and then move forward.
And I just want to quickly go in on these cuts too. We received a copy of that notice that was sent out to managers over at the system. And one of the first things that said we need to take a look at and possibly cut is the Sinclair Dental Center. And I had written about this center 2 or so years ago. This is one of the only centers in the state where some adult and some pediatric patients with disabilities can actually go for dental care. So to me, that sounds like that's not just fluff or even a construction project that could wait another year. That sounds like something that is critical for the state. Why is that being looked at?
I hope we get the funding to keep it going. There are a bunch of those programs to run an academic center. Do I need a dental program? I don't. In other communities, they don't have one. The patients are spread throughout the community. It's a great service we provide. But at the end of the day, you have to pay for some of these things, and we have to make the really tough choices. I need to keep the trauma center open. Nobody else has one of those. I need the stroke center open. So there's things that we will have to, unfortunately, force into those decisions of not doing them. And that's what I think people are missing. The consequences of not doing it are significant. And I do not, my mother would be mad at me. My dad's a preacher. My mother's a former politician. They're going to be really mad at me, but I'm in charge of this organization. We're going to have to make tough decisions. I hope I don't have to make them.
So, but put a timeline on that then. I mean, if this bill doesn't pass this session, I mean, are we talking about sometime this summer you're going to have to make a tough announcement?
Yes.
That close?
Yes.
Attorney General, I'd love for you to react to that. And then sort of I want to segue to
Just to tell you why we would make the decision. Implementing them takes time. You can't just break laws and close things. We would do it responsibly, but we have to make the decision and then implement them. And by the way, the state thing and the money, Washington's not helping us. So we better do something or it's going to get worse than the worst.
The reason I want to bring you in, Attorney General, is one, to your credit, you have been outspoken and aggressive about your concerns about healthcare for far longer than today or last week or last month. So you deserve credit for that. One of the things I also appreciate about you, though, is that you don't hold back about your concerns about the hospitals themselves. I'm sure you and John don't always see eye to eye on many things. So, I mean, I'd love for you to react to the concern of the possibility that, we're going to see major cuts at our largest healthcare provider, potentially beginning at least announcements this summer, and then kind of segue into, your big proposal today and sort of why you think your way is the beginning of the answer.
Yeah. So I think everything that John says is real and accurate when it comes to the crisis we face. What are the canaries in the coal mine? There's at least two. There's more than two. I see a lot of people that I've spoken to about this issue sitting out there in the audience. So thank you for being here. Doctors, providers, nurses, healthcare insurers. So here are the canaries in the coal mine. John can react to this. They bought 2 struggling hospitals in Massachusetts. Think about that for a minute. You're going to buy hospitals. You buy them in Massachusetts. Why? Because you'd much rather have a Massachusetts patient than a Rhode Island patient. Why? Because the reimbursements are higher. It's fundamental economics. He has never said that to me. He doesn't have to admit it in front of me, but you don't have to be a rocket scientist to figure that out if you know anything about healthcare. That's number one. Number two, Anchor Medical, okay? Anchor Medical was and is a fine practice. There were no mismanagement problems at Anchor Medical. Those were and are great doctors and smart business people. But what they realized was we can't make it as a primary care practice the way we want to practice medicine in this environment of reimbursement rates so low. And so John will tell you, he can say it himself, his organization subsidizes their primary care doctors about $150,000 a year, okay? So if we don't raise rates to the point where primary care at least breaks even, we're failing in primary care. Look, if you're coming out of residency and you have $250,000 in loans, which is the average loan amount for a medical school graduate, and you can go to Newport or Westport, and Westport's paying you, Massachusetts, paying you 30% more, that's where you're going to go. So we have to come to grips with the fact that this matters. And when the speaker, who I have a world of respect for, I don't know if there is a public official I respect more than the speaker, but here is the problem with we have no money. We have money. We have a $14.2 billion budget. But what we haven't done is budgeted for healthcare from the center, meaning when you sit down and build a budget, when you start building that budget, where is healthcare among your priorities? Plainly, it has not been a priority because we get to the end of the budget session and there's no money. Well, let's rewind 3 months, 6 months. Let's get in a room today, okay, and figure it out. Look, the money is there, as John said. On Saturday, look, I knew at today's press conference, the first question I was going to get about raising Medicaid to Medicare was, how much is it going to cost? And sure enough, Ian Donis, straight on the money, asked me that question. And everybody knows that's coming, So I called Keith Hoffman, my policy chief, on Saturday. I said, Keith, go find me $100 million in the state budget. He goes, you serious? Well, this is Saturday. I said, yeah, Keith. I suppose you need it by Wednesday. Yeah, Keith, we need it by Wednesday. So the fact of the matter is he found it. He found it. And we can find it. And when we start next year, we can find it if we think collectively that healthcare matters this much. I just don't think that in the leadership we have in our state, we understand the scope of the process because we're not out there speaking to the people in this room, the boots on the ground, number one, and we're not willing to make it a core function of our government. Meaning, if we're going to choose to insure our residents and people, as I said earlier, who are on Medicaid are working Rhode Islanders, if that's the choice that we make, then we have to pay the providers for providing the service. So we want our cake. What's the phrase? I can't get to it's been a long day. We want to eat from both ends of the candle. That doesn't make any sense either.
But wait, is the
We
number
want our cake and eat it too, or whatever it is.
you had that one right?
Do that.
Is the number you used 100 million? Is that roughly the number that you're talking about?
I think conservatively it's about 50 million. You know, EOHHS is going to have to figure that out. And they can. But look, we're going to be able to leverage federal Medicaid dollars. Look, everyone says it's going away. There's a lot of Medicaid in red states too. So let's just wait and see how that goes down the road. You can't say, oh my God, we can't do that because the federal government's going to take it when we don't know that yet. So we think it's about $50 million. You know, as I said at the press conference today, the governor, to his credit, found $10 million to try to shore up Roger Williams and Fatima yesterday. So it's there. We just have to make the hard decisions to get there.
I feel like, John, you're chomping at the bit to jump in.
Not really, but I just want to say I do think that the short answer to what Peter just said is if we don't ask the federal government for the matching funds, we're talking about leaving $180 million on the table. I would much rather be told no than never ask. We need to ask, and then the money will be there for our primary care doctors. We will take a few canaries out of that coal mine, but that's the opportunity in front of us right now if we want to do it.
And I actually just want to zoom out really quick. You had made mention at the top of your speech there that Brown Health had just purchased 2 failing hospitals in Massachusetts last year instead of purchasing Fatima and Roger Williams Medical.
Say that because there may be legit. I may have given him a problem about that.
There might be somebody sitting over there that had something to do with that.
I do have the antitrust authority for sure, but I think the economics make sense. I think.
Right. But I had written this story last year of like, why is the largest healthcare system in the state going to go save 2 hospitals in dire need across the border from Stewart? Why aren't they helping Prospect Medical Holdings? Yeah. And you and I had a conversation and you had said, well, actually, I had a conversation with John and Dr. Wagner from Care New England and said, you know, in a joking manner, you know what? I'll give you those and I'll give you the escrow from Prospect or from the private equity firm. Can you just kind of retell that story a little bit?
You know,
I'd like John to
remember we were sitting at the table in my office. We have a lot of conversations across the spectrum with healthcare, labor, management, insurers, everybody. And in this moment, I said, look, you know, we weren't sure what was going to happen with those hospitals. And I had Mike on my right and John on my left. I said, listen, I'll split the escrow in half. You each take one and I'll give you half the escrow. And they sort of chuckled, but they weren't buying. But let's turn the scenario on its head, because it is true that if John came to me and said, I want to buy both hospitals, there might be antitrust implications. Waits around it, maybe not. But here's the reverse of it. When I was concerned about that transaction, and I remain concerned about it, but I was concerned months ago, I called Yale New Haven and said, are you interested? No. I called Mass General. No. I called Deaconess. No. So what's my point? They're not coming here either, right? The same healthcare dynamics that don't make these hospitals attractive to the systems we know and frankly admire in our neighboring states, the reasons they don't want to come here, it's the same reason that John, even if he had no antitrust problems, is going to buy over in Massachusetts, because the economics here are much, much worse.
Go ahead, John. I see you want to answer this.
So let Maura in on this conversation. But you want to buy a hospital or two? No, I think
we've read about Daewoo too.
No, nothing really to add. You know, buying in Massachusetts, what we saw as an opportunity to enter into a new state. And we did do it for some of the reasons that Peter, that's not the only reason. And by the way, those hospitals, you know, especially St. Anne's, did quite well until they got purchased by an organization that had a different mission. I hope we can work things out so Fatima and Roger Williams stay open. But I do think it's back to this money issue. And if we can fix that, we'll be in good shape.
John, do you plan to expand Brown Health any more than that? Any more than those 2 hospitals you acquired last year?
Yes, but I have no idea where and when.
Would they be in Massachusetts or Connecticut?
Probably any state but here, because the general's been very clear about us expanding. We already have a lot of share in the state. I don't really look at Rhode Island as our market, but if you're the attorney general or you're others, you might look at it that way. So we look at our market as broader, and we take care of patients from different states all over the world. And I think having great health care here and making our organization really strong is what's really important to the people that live in Rhode Island. A strong Brown Health creates jobs and provides great care here. You can look at our neurosurgery program. We put a lot of money into that program over the last 7 or 8 years, and it is world class. People are coming from New York City. They're coming from Boston. I just had a colleague of mine that works at one of those health systems. They got their care down here. So having a great program, I mean, look at Brown University, pretty good university. They attract people from all over the world. That's what we want in Rhode Island, things that attract people here, new businesses here, new people here. That's what we want.
Maura, one of the things that I felt pretty encouraged by that you were saying before is a large chunk of students coming through your programs are actually staying in Rhode Island. If they were in the room today, though, hearing about we're going to buy anywhere but here, or we've got a massive crisis on multiple levels, what would you tell them?
I would say healthcare is in a bit of a crisis across the nation right now. I mean, as we know, CMS drives the whole reimbursement system. But I think there's a lot of opportunity within Rhode Island, and there's a strong community commitment within the state. I think if I think about how to address some of the challenges with primary health care, preventative health care is the first step, right? So I don't know what the regulations are, being relatively new to Johnson & Wales, but I've seen very effective pro bono clinics where students have an opportunity to learn from individuals that have various health conditions within the educational setting, and that increases their commitment to engage in community health practices. So, whether there's an opportunity for partnering with a medical organization to help us launch a pro bono clinic, I think that's one way. Another thing I think that would be really important is as a growing university in the healthcare field, we have many accrediting bodies that I report to, because each different health profession has a different accrediting organization. But in order for us to grow the number of students that we are going to graduate, we need to prove we have clinical sites. And so as we think about the competition in PA and NP, they have physicians that are also mentoring medical residents. The more effective way, I think, is looking at opportunities for physician extender growth, and that means providing more clinical placement. Could the state, and this is a question for the gentleman here, could the state provide a tax incentive? I know that it's been done in 1 or 2 other states within the United States, but a tax incentive to take NPs, nurses, and PAs into the hospital setting. That might help on both ends with respect to financial reimbursement, maybe not in a large amount, the volumes we're talking, but I think that's a potential solution.
It dawns on me, staying in the higher ed space, and I suppose I will be quick on this question, and maybe all three of you can kind of quickly answer it. There's this idea potentially of a med school at the University of Rhode Island. I know it's a little bit in the offing. I think the commission that's meeting has a full another year to continue meeting. But very quickly, is that a good idea? Is it a good idea to have a med school at URI? Maybe for all three of you?
I haven't studied that. I do think, though, that in terms of the crisis we face today, that won't fix it. Right. As somebody, as the head of Anchor said to me when I talked to him, that's like telling the patient that the inexperienced doctor will be with you in a decade. I mean, that's just
if not more,
if not longer. So, and would it be down in Kingston? If so, where's the teaching hospital? Would it be up here? I don't know all the dynamics of that. I do think, though, that I don't want to be distracted by things that won't fix the problem. And I think in some ways that's a distraction. And to think that that's going to solve our problem is is frankly avoiding the hard questions, which are the things we've been talking about so far today.
Laura, I see you kind of shaking your head. You
Yeah.
feel like it's a distraction?
I do too, because again, it's a very long-term solution. Again, my emphasis would be on engaging more of the physician extenders within the healthcare practice. Salaries are different, so maybe there's a marginal cost benefit to using those individuals. They're very well educated. They are supervised by physicians. Nurse practitioners, of course, can work autonomously, but my field of research is in rheumatology, and I'm on the American College of Rheumatology Board of Directors. And we have found that's what our emphasis within our professional organization is, really looking at how we can grow NPs and PAs to help us, because rheumatologists are in the same practical problem as primary care providers. They don't do a lot of procedural interventions, and so reimbursement rates are just making it completely difficult to be able to profit in any way, or not even profit, just be able to pay your staff and keep your organization running.
John, what do you think of a URI?
Second, third distraction to what we need to fix in healthcare today. I'd let the commission do their work, but it's a clear distraction. I mean, healthcare is the greatest team sport ever. It takes a whole bunch of people to make it happen. Yes, it's our doctors, but it's our nurses, it's our PAs, it's our technicians, it's the support staff, it's the revenue cycle, all those pieces. I mean, it's one of the joys of working in healthcare. It's a great team sport, but we need to make sure we support it financially so the team can take care of the patients.
I wanted to let Alexa ask a question here, but I had to jump in because of what you just said. So team sport, and I think this is an important question for the Attorney General. I gave you showered you with praise just now for
Here it comes.
The work that you've done on healthcare. Forget whether you're going to run for office. I ask you every 2 weeks. I'm going to continue to ask you for every 2 weeks. Doesn't matter. It's clear there is a rift between your office and the governor's office. I think even today, I think your office acknowledged that you didn't give very much of a heads up to the Department of Health about your proposal. How can we be playing a team sport if the governor and the attorney general can barely get along?
Yeah, look, I think, how do I put this? Yes. Look, I think it's important to work with those who will work with you and understand the problem. I have a lot of experience with the Department of Health over the last several years. They did a phenomenal job on COVID. But when it came to the regulatory process, they were behind us. There's just no other way to say it. When we were deciding the Lifespan Care New England proposed merger, arguably the largest and most important transaction in our state's history, Dr. Nicole Alexander Scott had just left. Dr. McDonald was coming on. And a couple of weeks before we knew we had to hit our deadline with the FTC, and I know Dr. McDonald. I did grand rounds with him at Rhode Island Hospital when I was U.S. attorney, but he didn't know a thing about it. And so what I have felt is lacking, whether I get along with the governor or not, my team certainly works with RIDO all the time. We worked with them on Prospect, and there are a lot of opportunities still to do that, regardless of my relationship with the governor. But the things we rolled out today, assuming the PBMs doesn't require, for example, the RIDO to know, and frankly, that's something we wanted to keep as a close hold. The ideas about primary care, I don't think that RIDO is rolling out legislation. That's a legislative function that we have as an independent office, constitutional office. So the things that we were proposing today, our own regulations, for example, around things like notifications, prior authorization legislation that we put in. I mean, all things that will move this forward are more matters for the Speaker and the Senate President, with whom I have great relationships. Look, I think that to play in this space, as a thought leader, you have to care about and think about and be serious about the problems. I feel like my office and I do that, and I'm prepared to work with anybody else who does. But I don't have a lot of patience for things that won't fix the problem, and I feel like it's necessary to speak my mind when I reach that point, because if I don't, everyday Rhode Islanders don't follow healthcare as closely as we do. will feel like everything's going okay. But when their hospital closes or they can't find a doctor, or like a family member of mine went to a hospital this weekend with a serious problem and the MRI machine wasn't working. Well, that's when you realize that the Band-Aid solutions aren't working and we need to do more. And so I'm moved by urgency for Rhode Islanders and not much else.
Yeah, and to your point, I guess when 20,000 patients wake up one day and find out that Anchor Medical is closing, that's they've had no idea that there potentially would be financial trouble. So I guess that speaks to that point. John, you come down from Massachusetts, you understand the Massachusetts landscape well. How does the political dynamic and that rift that I just mentioned between the governor and the attorney general, how does that play into? You have lobbyists, so you kind of, I assume, can let them handle it. But does the perceived level of dysfunction cause a problem for you as as the overseer of Brown Health?
Not for me, because I really focus on GSD, which is get stuff done. And so
you can swear here. It's okay.
Okay. He said it, get shit done. That's what we're about. And so I stay focused on that. And I spend time with the attorney general, the governor, his office, his staff, Speaker Sikarchi, the Senate leadership. I know it's changed a little, but we have to spend time getting this done because it's, we just have to overcome those problems if there are problems. And what we tried to do this year is focus in on this. We had 3 bills, but there's really one, and getting this matching fund seems to me like the opportunity that we have got to get over the goal line. And we did this with the Hospital Association. We worked with the community health centers. A big portion of the money would go to primary care and specialists that also need reimbursement help. So to me, it's if you know where the goal is, and the goal is trying to have a better health system in the state, that's what brought me here 2 years ago. I didn't come here. I said, oh, my God, isn't it a great system down here? When I worked at MGB, I worked on projects and we intentionally avoided Rhode Island because of the reimbursement system. We need to change that if Rhode Island's going to be successful. So in my view, there's a great opportunity here. We need to take it.
Before we get to questions with everybody, our colleague Steph Machado, who couldn't be here tonight, was like, can you please ask them this one thing? There are some of us who are in our 20s or early 30s, and we just lost our primary care physician, or we moved here 5 years ago, like me, and still can't find one in this state and has to travel to Massachusetts to get one. Do we even still need a PCP anymore? Is that necessary, or should we just go to specialists from now on? I think that there are some people in this room who are Anchor Medical patients who are wondering the same thing.
Oh, boy, let me take that one. I mean, I'm married to a primary care doctor, and a son who's a doctor may become one himself. Boy, if people like Hub Brennan disappear, we are in big trouble, because it's people like Hub Brennan who manage our healthcare. He's our air traffic controller. He calls us back. We can reach him through the portal. He orders our medications. You know what the specialists say? Call Hub Brennan. So I love my specialist friends. One of yours is the reason I'm walking today. And I love Dr. Oyalesi, by the way, if he's listening. But the Hub Brennans and the Shelley Johnsons are the ones who keep this was the whole concept behind medical home. How do we stay out of the ER? Hub Brennan keeps you out of the ER. The specialists aren't going to do that. So, oh boy, do we need primary care doctors. And we can make this, sorry for the pun, the hub of primary care if we invest in it and make it the place where primary care doctors want to come. But right now, they're checking out. They're retiring. They're going to concierge medicine. They're leaving the state. And they're leaving because they can't make it. My wife, when she came here, it's the last thing I'll say on this. When she came here, she was in a 3-person practice. That is almost inconceivable today, to be in a 3-person primary care practice. Why? Because the economics don't work. And it's not because they're not working hard. You talk to any primary care doctor, and I see them out there. I know how hard you're working. I understand it. And you're working really hard for your patients, just like the nurses are in the hospital, just like the other providers of primary care are. So we got to support them. You know, we don't appreciate the healthcare crisis until it's right here. And folks, it's right here.
John or Maura, anything to add?
I'd add, you have my phone number. If you need a doctor, we'll find you one.
That sounds like favoritism.
With the rest of this, yes, it is. But you brought it up, just like the speaker. Other people brought it up. We're glad to help. We are trying very hard to find people that need a primary care to be part of that team and get used to being part of a team of primary care doctors that can take care of you. And we need to have them in this state so that people come here. I mean, I love the idea of this being the hub for primary care. I mean, we can do it. It's just making it a priority.
Okay, one lightning round before I
Go.
open it up.
Yeah.
But for 2 minutes, I mean, what does healthcare in Rhode Island actually look like if the state doesn't get its shit together? If we don't start funding things, if we don't start restructuring things, if maybe we don't open this agency that the AG has proposed today, what does healthcare in Rhode Island look like 2 years from now?
Yeah, 2 years from now, there will be hospital closures. 2 years from now, when you walk into Rhode Island Hospital, you will not see a state-of-the-art hospital that you can be proud of. I mean, I've visited other hospitals around the country, and where my son went to med school and where he's doing his residency. Rhode Island Hospital can be there, but they are facing these reimbursement headwinds, and it's affecting everything from staff to the services they provide and how quickly they can provide them. So what it'll look like, you're not going to have a primary care doctor, or they're going to keep turning over because they're going to keep leaving. And we've all experienced, I think, some of that. And our hospitals are going to be providing fewer services. You want an MRI? Just like today. You want an MRI? I've gone through this. 2 weeks in Rhode Island, tomorrow in Foxborough. There's a reason for that. It's not coincidence. It's what we've been talking about tonight.
Maura?
I would agree. I can't imagine that the system can persist the way it is situated right now. And we need to really, in my perspective, look at a team approach with all of the health professionals engaged in this conversation and recruited to help to address our healthcare needs. But it is a very unsettling point in time right now.
A simple, unmitigated disaster, and it won't wait 2 years. So, and it will start in places we don't like and just get worse. So we need to fix it.
We got literally exactly 10 minutes before we all turn into pumpkins. We would love for questions. And so raise your hand. We'll call some people out.
Mr. Neronha, you're the only one this evening who brought up the issue of private equity. How much do you give them credit for our current situation? And how much do you feel we can do as a state in light of the federal environment to contain the interest of private equity that you alluded to as a different interest of health care as opposed to a health business?
Yeah, private equity destroyed Prospect National, which owned Roger Williams and Fatima. So they put those hospitals in a place where they were in trouble. But if you take that out of the mix, and that was the reason to go hard after them in that pitched battle a few years ago to get that $80 million in escrow to keep them open. But for that, they wouldn't be open. They'd be closed like a lot of other Prospect hospitals around the country, because private equity is always going to make their money. They don't care about healthcare. They care about money making. But that exposed for me, that first case that we really did when I became AG, exposed for me what we've talked about tonight, that even if at the time Roger Williams and Fatima had the world's best owners, remember, they have no endowment. They're a for-profit company, for-profit institutions. Because of the reimbursement rates and their patient mix, 70-30, 70 government, Medicare, Medicaid, 30% commercial, they can't make it. So no matter who owns them, you know, if we did send John over there with a great core of nurses that are already there and they work together over there, could they turn them around with these reimbursement rates? I'd still be skeptical.
Actually, just follow up on that. Private equity isn't just in hospitals. It's also in different health offices.
Oh, yeah. And we don't know where it is, Alex. And that's why we put in legislation today to give us more insight into it. And the truth is, if a public protection bill had not been vetoed last year, we would have more insight into it today. I mean, there are investigations that we would be doing today if we had the authority to do it. So no question, private equity is buying up all kinds of healthcare practices, eye doctors, primary care practices, and we don't have any real insight into that at all. And that's a very dangerous thing. So and they own a ton of nursing homes.
So we have no idea what they do. And we don't know if they own 50%, of the healthcare offices here in the state, 70%, we know nothing.
Well, that's true because we don't have a means of getting insight. We get insight into places through our regulatory authority. So people come to us and say they want to sell, they want to merge, they want to buy. Then we get into the books. I've never been in Landmark's books. I've never been in South County's books. I think that would be helpful. Rido can't go there either. But in terms of physician practices, you don't know that your practice has been bought by private equity until somebody tells you. If a doctor is being candid with you, they may tell you, but you may never know. And I think that's very, very problematic.
You talk about reimbursement rates being increased. What steps have to be taken to do that, and how realistic is it that those steps will be accomplished?
Yeah, look, I think it's very realistic. You know what? In our legislation, we have specific codes that would be increased. EOHHS and the Medicaid office would have to do a study quickly. They could do it quickly, we think, within a matter of months and make it retroactive to July. Our bill would go into effect the 1st of July. But it's not difficult to do. We just need to decide that we're going to spend not the money to do this, to figure out how to do it. That could be done. It's, are we going to spend the money that it will take to raise the rates to that level? We focused on primary care. Look, I think the Harry bill, the hospital bill is important. That's the one that would lift rates, Harry, across the board. But we focused on primary care in the legislation we announced today because, look, recognizing that bill's movement isn't what I'd like it to be, we got to at least get primary care stabilized right now this year without any doubt in my mind.
First step is we have to get the money put into the budget. Then how much goes to primary care and which codes we use, that's the next step. That's actually easy step. Getting the money allocated, use the matching funds, and move forward. Yeah, so if we put in, that's the whole proposal here with Medicaid is we put in $1 or we put in $100, we get 200 more. So that's 300. Our proposal is to take $90 million of state money, match it at the federal government, and then bring it back to pay for some of the things that Peter's talked about in primary care, hospitals, you name it. So, and having that kind of money, just to give you a perspective, hospitals in this state pay $214 million a year in taxes to the state of Rhode Island, right? If we got 270 million more, and let's say a third or 40% went to physicians and primary care, which would be way more than even Peter's proposing, we would be a long way to fixing we might not fix it all, but it would be fixing the problems in reimbursement for our physicians and stabilize a lot of the hospitals in the state. I would predict we can count on this federal reimbursement, but anybody that thinks they can predict what's going on in Washington, if you know how to do that, I'm buying. Actually, I probably wouldn't buy, but that we are not sure. But the more likely scenario, at least as we've looked at it, is yes, eligibility might get cut, but these matching programs benefit states all over the country. So, like Peter mentioned earlier, let's make sure we ask for the money, the matching money. Oklahoma's done this. Kentucky has done this. Ohio has done this. Yes, people in the Northeast have done it. This is not a magical mystery tour. This is a path that's been well worn.
My question is a little bit different than what you've been getting. We in Rhode Island seem to spend a lot of effort on the medical industrial complex and biotech instead of spending it on primary care. And we think it's an economic driver, but it has lots of unintended consequences like homelessness. How do we shift that balance so that instead of the state putting money into biotech, that it really puts it into primary care?
Well, look, I think, as I mentioned earlier, I think the answer to that is when you're building a budget, you build it. And look, I helped build the budget for the Department of Justice, which was a pretty large budget vis-a-vis U.S. attorneys' offices. You start with what you care about most, that matters most. That's primary care. We haven't done that. We really haven't done that with healthcare writ large, but we have to do it. And primary care, the problem isn't just money. That's a big part of it, particularly recruiting new doctors. It's lifestyle. PAs are not staying in the game either, and nurses aren't staying in the game either. Nurse practitioners, and I'm sure others, because the prior authorization burden, for example, is just over the top. And it's one of the reasons we put in a bill to eliminate it entirely for primary care doctors, with some exceptions for controlled substances and for folks who have problems with waste and abuse.
We keep asking, though, what are the prospects? What are the prospects of that bill? Because that feels like without knowing everything, it feels sensible. But I mean, do you have a sense of whether it's going to?
Well, not everybody agrees. I see Martha grimacing at me. We've had discussions, and they're at about, maybe we could get them to 70% if I'm at my most charming, which I'm not always, as you know. But look, I think that we've got to get that burden down. Doctors are spending far too much time away from their patients. Look, there's been good support among the rank and file in the House and Senate. We've got to get leadership, and ultimately the governor, of course, signed the legislation to get to where I think I am and we are. I understand they have a lot of other things on their minds, but we got to get them there. And I hope that we can. And one of the reasons I wanted to roll out so much today was to say, look, our office has done a lot of research, done a lot of work here. We've spoken to a lot of people. A lot of people have shared their time with us. We've got some good ideas. Let's do it.
I know that right now we are focusing on the healthcare crisis, but if you spend any time in the Capitol, you'll hear about the education crisis with, early education, RIPTA not having, enough for the budget, and all of these crises. And so I'm just wondering, what are some sources, untapped sources of revenue that the state has yet to explore, and what is the political will behind, looking into those sources.
And just to piggyback on that question, very simply, would you support a tax on raising taxes on the wealthiest Rhode Islanders?
Well, listen, I have no opposition to progressive taxes, meaning that the load is spread amongst Rhode Islanders according to their ability to pay. And if there are core things that we need to provide our residents, and we need to do it, but it doesn't always have to come at the expense of people paying more taxes. There are things that we can do, I'm convinced. So for example, if you were to sit down and look through the state budget today, there's no doubt in my mind that you could find places where you could find efficiencies. Number one, they can't do it all that way. There are other places. So for example, RICAP funds, which there's an enormous amount of money in RICAP. Some of that money could be basically effectively exchanged for general revenue. So there are some ideas out there. This is the Keith Project, some of the things they came back with. So there are ways to get there. There are ways to find those monies. But to me, again, when you're building a budget, you figure out what's most important to the people of the state. Education is right there. No question. Education, healthcare, public safety, things that you don't do without. And then you build out from there. And if you have enough for everything, great. But if you don't, you make the hard choices about the things that on the scale of relative importance matter less. Healthcare is too far to the side. It needs to come back to the heart of what we budget about and care about.
Just to push back, though, I don't feel like I heard a direct answer to the question, right? So
sure.
Show me, where would you say that you would see, $50 million, $100 million in potential savings, if it's not revenue going up,
sure,
where we cut?
Yeah, so we have a lot of money just right now sitting in RICAP, $1.4 billion, okay? There are ways to leverage that money to get money into the system today. When we come back next year, we don't know what next year's going to look like, right? So next year we come back and we start budgeting from the heartland. But there are ways we can fix this today. As I said today, the governor found $10 million yesterday. God bless him. That was a great thing that he did. Give him credit for that. We can find another $50 million for primary care this year. What John's talking about is a healthy investment by getting that 2-for-1 match back. Sometimes you've got to spend to get something back. We can find the money, but we have to, we keep talking about healthcare like it's optional. It's not, Dan. It's not optional for young people to not have a primary care doctor. It's just not optional.
I like how I'm that token young person in every room I'm in, but you still didn't answer the question.
Getting older.
Where are we going to tax the wealthiest Rhode Islanders? Where is it coming from?
I think you could do that. I think you could put taxes on things that cause our healthcare to go sideways, for example. Sugary drinks, if you wanted to. Go down the list. You could come up with things to do it, but I'm not convinced you have to do it. In other words, we don't know what next year's budget looks like, right? So you could leverage those RICAP funds this year, find the money. We don't have to buy the Citizens Building, for example, over in East Providence. We don't have to do that. Is that the choice that we want to make when we have hard choices to make? Look, I don't build budgets for the state. I got plenty of other things to do. But there's no doubt in my mind, because, as I said, if we're talking about $50 million for primary care and the governor found $10 million yesterday, I'm convinced that he could find this if he needed to. But let's be square. It's the speaker who's going to have to find that money. And I understand how tough that's going to be for him. And I'll help him any way that I can. But it's not optional to fix this. It's not optional. Healthcare is not optional. And until we get the notion that it's optional out of our heads, we're not going to fix it. We're not going to fix it.
I think we literally have to cut. I'm sorry, we have to cut it off. Go quick. You guys are okay with sticking around for a couple minutes, right? Sure. He seems like a reasonable human. You can do. Can we just give you a? Yeah.
When the bridges snafu with Deloitte, the governor announced last week
snafu is one way to put it.
644,000 people
and more. I think we found later.
That means that 65% of this state gets some kind of money. Residents get some kind of money from the state.
Well, yes and no, because this is over a period of time. So it doesn't quite, and some people have been on and off again. So it doesn't really correlate in quite that way. Look, so I think, as I mentioned earlier, there are working people who are working hard, but look, there are a lot of great small businesses out there, and I love small businesses, but they don't always provide health care to their employees. And so a lot of those working men and women in small businesses are on Medicaid. And we know because our office helps those people when there's a little bit of a snafu. So I'll wrap it up. And so look, this isn't the fault of the people of the state of Rhode Island. That's not what this is about. What this is about is our government, for example, failing children who have to have their teeth extracted because they have no access to dental care. Like, that's government failing. And we've known about that since Johnny Williams wrote that article last summer. And what have we done about it? Nothing. What does that say about our legacy and our commitment to children in the city of Providence when a girl who's 8 years old has all of her teeth extracted and we do nothing? That's what I mean when I say healthcare's not optional. It's not optional. And dental care is healthcare.
Peter mentioned that story. Just to give credit to our colleagues at the Providence Journal, Johnny Williams did a great job with that story. It was moving, and I know it's moved you a lot. We have to wrap up. I will say the last thought, and it's a slight question. Maybe let's go quick for you, General. When you talk,
they're picking on you.
I know. Well, it dawns on me as you talk about, well, look, I'm the Attorney General. It's not my job to manage the budget. There is a way for you to manage the state budget, and it would be to run for governor. And so let's end with that. Is there a chance that you're going to run for governor next year?
Yeah, look, there's always a chance. I have, when I was sworn in for my second term, I said there were two things that I was most worried about for Rhode Island. And one was climate change, and the other one was healthcare. I'm not shy about the things I care about. Healthcare is personal to me for a lot of reasons. And if I think it's necessary to get in a race to do something, I will. Look, I've loved being Attorney General because I work with great people every day. I'm a lawyer at heart. My friend Alan Fung was in the office. He knows how rewarding it is to be there. I've got to convince myself, first, in the first instance, whether it's the way to spend my 60s, frankly, and whether or not there is enough real things that a governor can get done to make a difference. And so I'm going to weigh those things and talk to friends and make it, and my family, of course, first and foremost, to make a decision this summer.
I don't know that I'd wish this on anybody, but I suppose you could live in Jamestown, run for state rep, and then try to be the speaker too.
I don't think that is very likely.
Listen, thank you all so much for being here tonight.
That was a special taping of Roadmap Live, Rhode Island's healthcare crisis, featuring Rhode Island Attorney General Peter Neronha, Brown Health President and CEO John Fernandez, and Maura Iversen, the Dean of the College of Health and Wellness at Johnson & Wales University. Moderated by me, Alexa Gagosz, and my colleague Dan McGowan. Rhode Island Report is a production of the Boston Globe in collaboration with Rhode Island PBS. Today's episode was produced by Megan Hall. Audio mixing and mastering by Marissa Ewing of Hemlock Creek Productions. Our music is from APM. Be sure to follow us on Apple, Spotify, or wherever you listen. I'm Alexa Gagosz. Ed will be back next week.
Looking to binge watch all your favorite PBS shows? You need Rhode Island PBS Passport, Masterpiece, Antiques Roadshow, Rhode Island PBS Weekly, and many more. Watch them all, anytime, and from any streaming device. Learn more about this member benefit at ripbs.org/passport. That's ripbs.org/passport.